split thickness skin grafts survive better. This is a Humbee's knife for split thickness skin grafts, asked many times. This is what the picture which you get after raising a split thickness skin grafts. You will see punctate bleeding points. This is how the donor site heals up, and you can reuse the donor site of split thickness skin graft. When we raise a split thickness skin graft, we carry out meshing of the graft, and meshing increases the surface area and it prevents seroma formation. That means it prevents accumulation of fluid beneath the graft. So, this is known as meshing of the skin graft. This is a full thickness skin graft which I have told you can harvest from behind the ear, and it has better cosmetic outcome. This is a new topic which has been added. I just want you to know basic points. Return of sensation in a graft, reinnervation starts by 4th to 5th week and is completed in 1 to 2 years. Pain returns first and light touch and temperature appear later. Graft survival is by 3 methods. You have imbibition is the first, which lasts for 24 to 48 hours, then inosculation 2 to 4 days, and neovascularization beyond 4 days. The most common cause of graft failure is collection beneath the graft or hematoma beneath the graft. That is the most common cause. Infections can occur, movement or shearing force, or a poor recipient bed. This is what a graft looks like if it fails. Ulcers are also frequently asked. So, which of the following is likely to be true regarding this ulcer? Now, this ulcer is in the sole of the foot, and sole of the foot ulcers are commonly trophic ulcers. Trophic ulcers would be seen in patients with diabetes, in patients with neuropathy where they can't feel things. So, there is decreased posterior tibial and dorsalis pedis pulsation. This is false, this would be more in arterial. Loss of sensations over the foot is true. Positive Trendelenburg sign, Trendelenburg will be seen in varicose veins. That will not lead to an ulcer here. We will talk about varicose ulcers, and pain on compression of calf is a sign of DVT. So, this is also false. The correct answer is loss of sensation. Now, venous ulcers or varicose ulcers are seen in the gaiter area or the area over the medial malleolus. This is the typical site for venous ulcers or varicose ulcers. Arterial ulcers will be seen when there is shiny skin, absent pulsations, shiny skin, absent pulsations would be there. There will be muscle loss. These are the signs which you will see, and arterial ulcers have punched out edges. They will have punched out edges. Trophic ulcers I have already explained to you. This is another diabetic ulcer is also an example of a trophic ulcer. Tubercular ulcer has undermined edges. Tubercular ulcer has undermined edges. So, these ulcers and the images you should know for the exam. Which of the following are true regarding frostbite? Now, one thing which I want to tell all of you is that please solve the UPSC CMS papers for the last 2 years. One trend which I have seen is that whatever surgery topics are asked in the UPSC exam, invariably they will either be asked in NEET PG or in INI-CET. So, do not miss out on the UPSC CMS paper. This is something which routinely students do not solve. Please do solve them. I am telling you, you will thank me later because similar topics are asked in NEET PG and INI-CET. So, definitely last 2 years UPSC CMS papers you should solve. They are available on their website. If you have any doubts regarding the answers, you can always ask on the Marrowlinks Facebook group, or you can message me on my Instagram ID, that is left handed surgeon. But please do solve them, they are very important for the exam. So, frostbite was asked in the UPSC exam this year as well. Which of the following is true? So, amputation is done in severe cases, antibiotics and analgesics are not used, rewarming is not done, we have to clean and dry the area, right. So, we have to keep the area clean and dry, this is true. Rewarming has to be done, so this is false. Antibiotics and analgesics are used in these patients. We have to use them in certain patients, not in all patients, and we have to carry out amputation in severe cases. This is also true. So, the absolute true statements are 1 and 4. Antibiotics and analgesics. So, antibiotics are not used in all cases, only when it is infected. So, the correct statement is 1 and 4. Frostbite is when ice crystals are formed in the tissue and they cause membrane injury and microvascular damage. Reperfusion injury can occur in these patients. Stage 1 is hyperemia, stage 2 is large vesicles, stage 3 is hemorrhagic vesicles, and stage 4 is when muscle or bone is involved. Trench foot is when there is prolonged exposure to cold and the tissue is wet and there can be microvascular damage. Gradual rewarming needs to be done in these patients. Don't rub the tissue as it is extremely painful. This is what was asked in the UPSC exam this year. Be aware of reperfusion injury. Hyperkalemia and acidosis can occur in these patients, and if gangrene is there, we have to carry out amputation, but we wait for the line of demarcation to form. Moving on to questions from endocrine surgery. A 37-year-old nulliparous lady who's on OCPs, oral contraceptive pills, since the last 3 years. She comes to you, her mother has had breast and ovarian cancer. What will you advise as the next step in this patient? So, because the mother and the sister has had breast and ovarian cancer, she is at high risk, and we know there is hereditary breast and ovarian cancer syndrome, which is due to BRCA mutations. Now, OCPs, low dose OCPs are not linked with breast cancer. So, this is out. Prophylactic mastectomy we do not do straight away till we have tested for BRCA gene. Annual mammograms, she would require mammograms, but she would also require MRI because she is young. So, the first thing which needs to be done is she needs to be counseled for BRCA gene, and a genetic testing needs to be carried out in this patient. So, this is the latest position statement for mammography or screening. Women more than 25 should undergo formal assessment, and with average risk they should start screening by 40 years. So, women with average risk annual mammogram should start at 40 years of age, but women with higher than average risk, as you can see, BRCA carriers, or if there is prior chest wall radiation between 10 to 30, then at 25 years we should start with MRI in these patients. If they have a strong family history only, then we start at 35 years of age. But what I am trying to highlight is that strong family history you need to start early. What are the indications for BRCA testing? So, if there is a BRCA mutation in a blood relative, if there is history of ovarian or breast or peritoneal fallopian tube cancer, if there is history of ovarian and breast cancer in the same patient, if one or more relatives have been diagnosed with breast cancer less than 45, history of bilateral, history of triple negative or male breast cancer, or first or second degree relative with ovarian cancer and breast cancer less than 45, then we should offer BRCA gene testing for the patient. Breast cancer patient on tamoxifen since the last 5 years, she wants to conceive. When should she stop tamoxifen? So, we get a lot of patients, I have a lot of patients who have been on tamoxifen for many years, and some of them are desirous of having a pregnancy. So, firstly you need to understand that after treatment completion, we wait for at least 2 years. So, at least 2 years of tamoxifen has to be given before you stop it for the patient to become pregnant. Why do we have to stop it? Because it is teratogenic. So, we have to wait for 2 years of tamoxifen and then only we can stop. So, we usually stop it 3 months before and then we ask the patient to conceive, right. We stop it 3 months before and then we ask the patient to conceive. All of the following release neurosecretory granules except. So, paraganglionoma, medullary thyroid cancer and pituitary neuroendocrine tumors, these are all neuroendocrine tumors and they secrete neurosecretory granules. Adrenocortical tumor does not. So, the correct answer here is adrenocortical tumor that does not secrete neurosecretory granules. Moving to urology questions, which of the following is true about clear cell carcinoma of the kidney? So, contains glycogen and lipid, yes, because this glycogen and lipid, when you fix the slide or when you are fixing the specimen, this gets dissolved. So, that is why you get a clear cell appearance. They are mostly sporadic, this is true. It is due to deletion of chromosome 3q, this is false, it is 3p, and it arises from proximal convoluted tubule and not DCT. So, the correct answer is 1 and 2. Clear cell is the most common type, deletion of 3p and 6p, and this can be associated with von Hippel-Lindau syndrome and commonly arises from the proximal convoluted tubule. Papillary renal cell cancer can be seen in hereditary papillary RCC syndrome. CMET mutation can be there. Some OMA bodies would be seen. PCT is more commonly affected than DCT, and this can be associated with long term dialysis therapy as well. So, this is what papillary RCC would look like. Chromophobe RCC has the best prognosis. This is loss of multiple chromosomes like 1, 2, 6, 10 and 13, commonly seen with Burt-Hogg-Dube syndrome, and you get plant-like cells and raisin-like nucleus in these patients. This is chromophobe RCC where plant-like cells and raisin-like nucleus is seen. A 35-year-old comes to the OPD with right flank pain. CT image is shown below. Which of the following statement is incorrect? Now, this was a CT image where there was a hydrated cyst, where there were hydrated cysts, multiple hydrated cysts in the kidney. So, they are asking about hydrated cysts. We have to give albendazole. It is caused by tapeworm infection. This is also true, and we know that dog is the definitive host in these patients. Sheep is the intermediate host and man is the accidental intermediate host. Man is the accidental intermediate host. The most common organ affected is the liver, but kidneys and lungs can also be affected. Leakage of cysts can cause anaphylaxis, which is why we have to be very careful, and FNAC is required before surgery. This is false, because if we do an FNAC, we can rupture the cyst and there can be anaphylaxis. So, serology and imaging can clinch the diagnosis. On imaging, you can see here, and we can do serology to clinch the diagnosis as well. A patient develops loss of sensations over the root of penis following laparoscopic hernia surgery. Which of the following nerves would you implicate? So, the most commonly injured nerve during hernia surgery we know is ilioinguinal, and ilioinguinal is during open surgery. Sometimes during laparoscopic surgery also this can be injured, and this can give rise to loss of sensations over the root of penis. So, you should know this, it is ilioinguinal nerve. Now, you should know the complications of open inguinal hernia surgery are hemorrhage, injury to cord structures. Most common nerve injured is ilioinguinal. Most common nerve entrapped in the mesh is iliohypogastric, and this can also give rise to pain. Chronic inguinal pain can be there because of entrapment of the iliohypogastric nerve. There can be recurrence and wound infection as well. Laparoscopic surgery, there are two procedures. You can have TEP, that is total extraperitoneal repair, or you can have transabdominal preperitoneal repair. The triangle of doom and pain has been asked multiple times in the INI CET exam. You should be aware of triangle of doom and triangle of pain. Triangle of doom is bounded by the vas, the testicular vessels and the peritoneal reflection, and you have the external iliac vessels, the genital branch of genitofemoral nerve in this triangle. So, no stapler or tacker should be placed in the triangle of doom, otherwise it can give rise to bleeding. The triangle of pain is lateral to it. Triangle of pain is bounded by the testicular vessels. You have the peritoneal reflection and the iliopubic tract superiorly. The most commonly injured nerve here is the lateral cutaneous nerve of thigh, and that can give rise to meralgia paresthetica. That means there can be altered sensation and pain along the lateral part of the thigh, that is meralgia paresthetica. If you combine the triangle of doom and pain, you get the trapezoid of disaster. No stapler or tacker should be placed here. One more term is corona mortis. Corona mortis is an abnormal communication between the obturator and the iliac vessels, and this is behind the pubic tubercle. If this gets injured, it can also give rise to torrential hemorrhage during surgery. So, these were the various questions which were asked in the INI-CET exam. I have already told you a distribution. I have done them topic wise so that you can note down these topics and you can revise them before the exam. One thing which you should remember, whether you are preparing for the INI-CET exam or the NEET PG exam, at least leave 1.5 months for yourself for revision. So, you should try to finish your course in such a manner that before any exam at least you have 1.5 months for revision, so that you can revise, because if you do not revise, then it is very difficult for you to get a good rank. And what to do in the revision? You need to do the high yield topics, the previously asked topics, which I have repeatedly covered up when I was talking about these questions and these topics. Also, if you are running short of time, you can make use of the revision videos and the MCQ discussion videos, where all the faculties have covered these points. So, rather than leaving a subject completely, at least do the revision and the MCQ discussion videos, and that would mean that you have at least done 60 to 70% of that topic. Right. Thank you very much. If you have any questions, you can post them in the comment section or ask me the academic queries in the Marrow Links Facebook group. Thank you.